You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for July 10th, 2020. This week, COVID, sacubitril valsartan, left atrial appendage occlusion, and statins. First, a brief COVID update. In the United States, the rate of growth of cases over the last 2 weeks is about 1.15x, which is significantly greater than my last podcast. My colleague at Medscape, Dr. Topol, tweeted yesterday that every day sees a record number of cases in the last week. Wednesday of this week, there were 62,000 new positives in one day. Now, the U.S. deaths 2 weeks ago were about 120,000. This week, they are about 135,000. The rate of rise is 1.06x, which is steady, except just moments before I recorded this podcast, the COVID tracking project reported that the 7-day average for deaths is now moving up, which is to be expected with these huge numbers of cases. Of course, there's a lag. So much has changed in the last 2 weeks. States that were quiet when New York, New Jersey, New Orleans, and Boston were surging are now seeing massive numbers of cases and hospital admissions. Some hospitals are getting close to being overwhelmed. A colleague in Austin wrote to me and said that their hospital is okay, but they're seeing many more cases. News reports have many hospitals in Florida, Arizona that are reaching ICU capacity. The percent of positive tests in some cities is strikingly high, and this means that there is massive community spread of the virus. Of course, we are later in the pandemic now, though still probably early overall. COVID seems to be increasingly infecting younger people. Now, while younger people do better with the condition, on average, this is still a very worrisome finding because A, increasing prevalence among the young will increase the odds of spreading the virus to older, more vulnerable people, and B, not every younger person gets off easy. We have seen a number of severe cases of COVID here that occurred in seemingly healthy younger patients. Availability bias cannot be overcome, and after seeing these cases firsthand, I now better understand the alarming words from the frontline clinicians in Boston and New York in March. Internationally, the story seems to parallel the focal nature here in the U.S. Some countries struggle to control the virus in Brazil, Mexico, India, for instance, while other countries like Australia, Netherlands, Denmark seem to have a handle on it. I heard yesterday that even hard-hit Britain is opening back up. The good news, there are numerous vaccine trials, and gosh, do we ever need a vaccine. Final thought. Every day when I walk through our hospital cafeteria and I see the spread-out tables, one person per table, all facing the same direction, it makes me think we're living through a science fiction novel. It's just crazy. Next topic, sacubitril valsartan, or SV. 6 years out from the landmark Paradigm heart failure trial, I'm gaining confidence with SV. And I say SV for sacubitril valsartan because A, I do my best to avoid brand names. Pharma doesn't need us to help them market their drugs. And B, sacubitril valsartan is a lot to say. As an electrophysiologist, I see many patients in pre-ICD evaluation and a lot of patients with ICDs who have reached battery depletion, and rightly or wrongly, the LV ejection fraction is central to the ICD decision. Over time, I've seen a number of patients improve their EF after taking SV, sacubitril valsartan. That is why I was drawn to a small but intriguing observational study from Italian investigators. This was presented as an abstract at the virtual European Heart Rhythm Association meeting. The authors measured ejection fraction at baseline, and then after 6 months of taking SV, these patients had heart failure with a reduced ejection fraction and ICDs. The primary outcome of this study was improvement in ejection fraction, and the clinical implications are obvious, right? If the drug can improve EF, we may be able to avoid ICD implantation and or replacement. They enrolled 230 consecutive patients who had heart failure, low EF, and ICDs. At enrollment, about 68% received the lower dose and the rest a higher dose of SV. At 6 months of follow-up, the mean absolute increase in EF was only 4%, but 1 in 5 patients achieved an EF greater than 35%, which of course is the cutoff for ICD eligibility. Now, I don't mean to make too much out of a meeting abstract of an observational study, but this is provocative and is plausible, and it's consistent with my observations. So I went through some of the clinicaltrials.gov site looking for ejection fraction studies from Paradigm, and there were none. Paradigm PI Dr. John McMurray confirmed by email that there were no EF sub-studies from Paradigm. I did find a number of observational studies on the topic, the best of which is the PROVE-HF study published in JAMA last year. This was an uncontrolled study of about 800 patients on SV and found that at 12 months the ejection fraction increased from 28% to 37%. That was a highly significant increase. The theory, of course, is that reverse and beneficial remodeling is the putative reason for the drug's improvement in outcomes. Now, potential improvement in cardiac structure and function directly pertain to ICD net benefits. Recall that the old trials of ICDs showed significant mortality benefits, but the more contemporary Danish trial, which was limited to non-ischemic cardiomyopathy patients, found no incremental ICD benefit over guideline-directed medical therapy. Now, this is almost certainly related to the fact that as heart failure therapies improve, the incremental benefit of ICDs decrease. And these forces are important in the decision to implant a new ICD, but they're hugely important in the generator change decision. A generator change is different. Complication rates are higher in gen changes. Patients are older with more comorbidities. An ICD infection after a gen change is catastrophic because now a patient faces a lead extraction. That's a procedure with significant risk. So here's a thought experiment. Think about this. Imagine if you would do a randomized controlled trial of patients with an ICD for primary prevention who have never received the shock. One group gets the change, the other group gets no surgery and maximal medical therapy with SV, sacubitril valsartan, if it could be tolerated. Next topic is left atrial appendage occlusion, specifically the PROG-17 trial. Now, the first thing to say about left atrial appendage occlusion with a device is it would be great if it worked. I mean, atrial fib is a growing global health problem, and taking a daily anticoagulant is a pain in the butt. A procedural solution holds immense promise, but the onus is on the advocates to prove that the device is beneficial. A brief comment on the background here. We must remember that left atrial appendage occlusion versus warfarin was hardly convincing. The PROTECT-AF trial did not pass FDA muster, and the first co-primary efficacy endpoint of PREVAIL, which was a composite of stroke, systemic embolism, and CV death, missed its non-inferiority margin, and that non-inferiority margin was extremely lax. Why did it not meet non-inferiority? Because ischemic strokes were more than twofold higher in the device arm compared with warfarin. Now, crucially, patients who could not take anticoagulation were excluded from the regulatory trials, but these are the patients that are most commonly implanted with the device now. And that is why the DOAC versus left atrial appendage comparison in PROG-17 was such an important trial. I wish that the trial results supported the author's conclusion, but it did not. Now, PROG 17 was a non-inferiority trial, which is totally fine. Indeed, this is a good way to study left atrial appendage occlusion, because if left atrial appendage occlusion proved not to be worse than a DOAC, and it added safety in terms of less bleeding, you could consider it in advance, especially since it would be more convenient not to spend the dollars on the expensive anticoagulants and not to have to remember to take them. Now, how would such a non-inferiority trial look? The DOAC trials have shown the way. Rely, Rocket AF, and Aristotle all compared DOACs to warfarin and measured non-inferiority for efficacy, and that was narrowly defined as stroke and systemic embolism. Then the authors tested safety in a superiority design. That is because it is not medical progress to have a more expensive drug that is equally good but not any safer. But this is not what PROG 17 authors did. Instead, they chose everything bad that could happen to a patient with AFib, and they put that into a composite endpoint. So in the composite endpoint of PROG 17 was stroke or TIA, systemic embolism, also bleeding, also CV death, also procedure-related complication. The study was done at 10 centers in the Czech Republic, about 200 patients per arm. These were high-risk patients with a mean CHA2DS2-VASc of 4.7. And in the end, 47 primary outcome events occurred in the DOAC group and 38 in the left atrial appendage occlusion arm, and this resulted in a hazard ratio point estimate of 0.84, and the confidence intervals ran from 0.53 to 1.31. Now that upper bound of 1.31 was less than the non-inferiority margin of 1.47, so the authors declared non-inferiority. And so the paper sits in JACC with a conclusion that left atrial appendage occlusion is non-inferior to DOACs. It will be cited in the future. It will be incorporated into systematic reviews and meta-analysis. But sadly, this is incorrect. You cannot do non-inferiority trials like this. Multiple people I spoke with for my written commentary on this trial made clear that you cannot combine endpoints of efficacy and safety in a non-inferiority trial. It's circular logic in the case of stroke prevention. Recall that no difference is a positive finding in a non-inferiority trial. Dr. William McIntyre said it well. He said, if you include events that you expect to trend in opposite directions, say thrombosis and bleeding, you bias to the null and you make non-inferiority easier to obtain. Ricky Turgeon wrote on Twitter that safety, bleeding, is the justification for non-inferiority testing. Safety is the justification for non-inferiority testing. So a look at the components of the composite endpoints in PROG 17 really provides no compelling signals. The efficacy events, stroke and TIA, were similar, the hazard ratio 1.0, but the upper bound here of 2.5 far exceeded the non-inferiority margin of 1.47. Now I know the individual endpoints were not powered, but there is no advantage here. Safety endpoints were also similar. The point estimate of the hazard ratio was 0.81, with a lower bound of 56% less bleeding with left atrial appendage occlusion or 52% more bleeding, basically a wash. The Canadian academic electrophysiologist Jason Andrade was surprised that left atrial appendage occlusion wouldn't show a stronger signal of less bleeding in such a high bleeding risk cohort. But I'm not surprised, and this is because left atrial appendage occlusion can expose patients to bleeding risks from A, the procedure itself, B, taking antiplatelet agents, and C, a not insignificant number of patients with a device remain on dual antiplatelet therapy or anticoagulation. I ask you, go back to the Holmes et al. Meta-analysis of PROTECT and PREVAIL. If you count all bleeding, including the procedural bleeds, there is no difference. Now, the likely reason the PROG 17 authors chose this design is not nefarious, and I mean no ill will with this criticism. I am almost certain the composite endpoint was chosen for power reasons. In the supplement, they explained that it would have taken 7,000 patients to test non-inferiority on efficacy grounds. But that does not change the fact that we cannot and should not cite this study to suggest the device is non-inferior to direct-acting oral anticoagulants. What's more, it makes me terribly sad for our field that the recent U.S. registry study of left atrial appendage occlusion included, get this, 38,000 procedures. If only a fraction of these patients were randomized, we would have answered a crucial question in cardiology. Now, the final topic today is statins, and I want to start this section with a quote from the highly cited BMJ paper from 1984. Douglas Altman, the late British statistician, wrote, "We need less research, better research, and research done for the right reasons." Now to the latest study on statin use in the elderly. JAMA published this large observational study. I want to first say that observational studies are not useless. They can tell us about procedural complications, real-world uses of different therapies, temporal trends, and sometimes they can raise good questions to be tested in RCTs. The problem with observational comparisons is that the two groups are not randomized, and thus one never knows if the observed differences are due to the treatment or baseline differences. Of course, statistical maneuvers can help minimize biases, but statistical tools can only be used on things that are in a data sheet. And doctors are not robots. We choose to treat or not treat for lots of reasons, and not all of them are objective. The thing about statins is that these are the most studied drugs ever. I'm pretty sure that more patients have been enrolled in statin trials than any other trials. I mean, maybe aspirin is close, but statins are up there. The authors asked an important question. Do statins lower the risk of death in patients older than 75 who have not yet had a cardiac event, basically primary prevention? The problem is that no matter how many patients you include in a non-randomized study, you don't approach the value of an RCT. I think it was Dr. Robert Ye who said adding more patients to an observational study may even increase the biases. This was a retrospective cohort study that used propensity score overlap weighting, and it included about 325,000 participants from the VA health system. And the study concluded that new statin use was significantly associated with a lower risk of all-cause death and cardiovascular mortality. The problem here is that in absolute terms, the reduction in overall mortality with statins was far larger than the reduction in CV death or cardiac events. For instance, overall mortality was about 1.9% less in those who took statins, but CV death was only 0.3% lower, and cardiac events was only 0.6% lower. Why does the effect size for overall mortality dwarf the reductions in CV death and cardiac events? Likely because healthy older adults are more likely to be prescribed a statin. For example, confounding. If you want to know whether statins benefit older adults, you have to do trials. And until these are done, the authors cite a couple of ongoing RCTs of statins in elderly patients. The answer is simple. You have a discussion with an older patient. You tell them statins have been shown to reduce cardiac events, but most of the studies included mostly younger patients. You also tell patients the odds of serious adverse effects are low. Some older patients will trade the disutility of taking a pill every day for the probabilistic reduction of events. Other adults say, no way, it's not worth taking another pill. But citing an observational trial, no matter how many thousands of patients it includes, is the wrong answer. I mean no malice to the authors or JAMA, but medical science would be just fine without any further observational trials of statin drugs. So that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, if you like this podcast, please consider taking the time to tell a friend, writing us a review, giving us a rating. That way other people can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.